Yes, your screen is visible.
So this is the first OSCE. All the fellows can see the screen. They can write in the chat box the answers of the OSCE. After that, we'll share the answers. So first, what are the components of KMC? Second is which oligosaccharide present in human milk inhibits H influenzae? Third are the name two very long chain PUFAs present in human milk. And fourth is what is the predominant method of heat loss in a newborn when nursed in an incubator?
I think we can go by 2 questions at a time. You can, or maybe just one question at a time. Just read out one question, they'll answer, and then we'll go to second question and so on.
Okay. Second question is identify this device and what is it used for?
No, I think let's cover the first OSCE.
Okay.
One question at a time for this OSCE.
Okay.
Then we'll go. You have made all the OSCEs first and then answers will come?
No. First question and then answer.
Okay. Okay. So I think let's discuss these four first. Yeah. Let's discuss these first. I think they have written in the chat box.
Few of them have written. Second also, you can answer if. So first answer is right, skin to skin and early breastfeeding. This is the answer for first. You can read the second one and answer. Answer for third.
I think we have given enough time for these. Let's discuss these.
Answer for first is skin to skin contact and early exclusive breastfeeding. Second is fucosylated glycans. This is present in human milk, which inhibits H influenzae. And two PUFAs, which are present in breast milk, are arachidonic acids and DHA. And radiation is a primary mode of heat loss in a newborn when nursed in an incubator. So should I go to second one?
Yes, yes.
So what is a device and what is it used for?
I think we can discuss this.
Okay. So this is not an EEG. This is an near infrared spectroscopy. This is actually a technique which is used on the concept that light of wavelengths 680 to 1000 nanometer is able to penetrate the human tissue and is absorbed by oxyhemoglobin and deoxyhemoglobin. So changes in this is detected by the light levels, and therefore it helps in monitoring the cerebral oxygenation. Is everyone clear?
Yes, I think this was quite interesting. We can proceed.
Okay, this is a third one. Name the measurement and what is its implication? These two measurements. So the answer for this is, the first one is ventricular index. It's the distance between the midline and the lateral border of the ventricle. And the second one is anterior horn width. It's a depth of the frontal horn taken just in front of thalamic notch. So more than 3 millimeters is suggestive of ventriculomegaly and more than 8 millimeters is suggestive of hydrocephalus.
I think most of the delegates have answered this correctly in the chat box.
So fourth one is what is support trial and for what it was done. And second one is a boost 2 trial. What does boost stands for and how is it significant relation to ROP and mortality? So support trial is surfactant positive airway pressure and pulse oximetry trial. So it was a trial which was where the low oxygen target saturation was 85 to 89 was compared with the higher oxygen saturation, and it was seen that the mortality was increased, but the ROP rates were reduced, but the death was significantly higher. And the boost trial were benefits of oxygen saturation targeting trial. So all these are a part of neoprom. Support, boost, cot. Fifth one is a newborn babies on mechanical ventilator, and with these settings, with FiO2 of 40%, and ABG showed pH of 7.24, bicarb of 23, PaO2 of 60 and PaCO2 of 50. Calculate the alveolo-arterial oxygen gradient, that is AADO2. Anyone for this formula for calculating AADO2? So AADO2 is calculated by 713 into FiO2 minus PaCO2 minus PaO2. So in this, when we calculate it, it is in this equation, if we add, if we put, and it comes out to be 175, this actually signifies the, normally there is ventricular, VQ mismatch. So normal also there is a physiological VQ mismatch, but if there is severe hypoxemia and there is a significant VQ mismatch, there will be AADO2 will be significantly increased. So if it is more than 40, it is definitely abnormal. In this case, it is 175, which is very, very high. Next one is number 6, a 37-week male with birth weight of 2.8 kg was delivered by emergency LSCS and developed respiratory distress soon after birth. Started on CPAP, but respiratory distress was persisting. Therefore, put on HFO with a MAP of 20, frequency of 15 Hertz, FiO2 of 100%. After 2 hours, ABG shows pH of 7.2. PaO2 of was 40, PaCO2 was 60, and bicarb of 24. Calculate the oxygenation index. What's the formula for OI? So most of you are right in this. OI is MAP into FiO2 into 100 divided by PaO2. This baby had MSL and went into severe PPHN. So the OI came in, this was 50. It's very high. Usually more than 20 we start with the INO. So what's the name of this diagram? Okay, this, I think everyone knows it. Most of them have written. So this is a forest plot. As you can see, so each square represents a treatment effect of an individual study, and this is a line of no effect. The size of the square is proportional to the relative weight of the study, and this is a diamond which shows this is a pooled effect size, which shows as a diamond, and the point estimate is the center of the diamond. So the 95% confidence interval is the width of this diamond. So, so the width of the diamond represents a 95% confidence interval. The diamond crosses the line of no effect. The meta-analysis does not significantly favor experimental or the control group. So next is what is Schwartz equation, which is used for calculating GFR. And second one is the intrauterine exposure to NSAIDs. What is the likely complication associated with neonate after birth? First, you can answer the first one. What is Schwartz equation? So yes, you're right. First one is the K, which is constant into length divided by creatinine, where K is 0.33 for preterms and 0.45 for term babies. And it is used to calculate GFR. Suppose the drugs which are given to term or preterm babies are nephrotoxic, we have to calculate the GFR and we have to write the dose according to the GFR. And for nephrotoxic drugs, we have to calculate it. And second one is the PPHN. The babies who are like intrauterine exposure to NSAIDs can result in PPHN in a newborn. So this is OSCE number 9. It has 4 parts. So I think you can answer one by one. As per NFHS 4, how many babies are able to begin breastfeeding within 1 hour? You can take a guess also. Second one is how many visits and on which days Asha is supposed to visit for the care of newborn and postpartum mother in institutional delivery. Third one is as per INAP, single digit NMR is to be achieved by all states by which year? Fourth is in MAA program, what MAA stands for and what is the aim of this program? So the answer for first is only 42% of the, according to NFHS 4, only 42% of the babies are able to begin breastfeeding by 1 hour. And for Asha visit, total 6 visits are is supposed to done by Asha workers, and it is at day 3, 7, 14, 21, 28, and 42. And by single digit, this NMR is to be achieved by 2035. And MAA is Mother's Absolute Affection Program, and which brings focus on promotion of early breastfeeding. And the last one is this diagram, where you have to identify this. What is this arrow signify? So this is not auto trigger, but this is auto peak. So it is mostly seen in babies who are sometimes in babies with acute severe asthma or patients receiving inverse ratio ventilation. Sometimes when we do not give them time for expiration. or we have increased the respiratory rate, but or increase the eye time, but there is no time for expiration. So sometimes it leads to increased work of breathing, barotrauma, hemodynamic instability, and difficulty in triggering the ventilator. So yeah, this was the last one. Anyone, any doubts on this? Anyone? Should I stop share?
Yes, I think you can stop. Thank you, everyone. I think, first of all, thank you, Dr. Kumar Ankur and Dr. Sunaina, for taking out time for this session. And thank you all the participants. There were at one time, there were close to 75 participants, which is quite good. And thank you, everyone. Both the cases were wonderfully discussed, and the OSCEs were quite informative. And I think all the participants, they participated quite well in the OSCEs also. Thank you, everyone. Thank you for the time. If anyone has any comments or any suggestions, please put them in the chat box.